Dear students, in this video, I'm going to discuss about refractory intracranial hypertension. It is our common experience in the ICU that a lot of patients who have traumatic brain injury or other forms of brain injury with intracranial hypertension are often resistant to the first line. Now, how do we approach these patients? What are the consequences if we approach, and what might be the consequences without approach? This is a very important part of decision making in the ICU, and I will want to touch upon the important points pertaining to this aspect. Let us start with this patient, a 28-year-old male who has no comorbidities, is brought to the ED after a high-speed road traffic accident. He was found unconscious at the site, and on arrival, he is found to have a GCS score of 6, E1, V1, M4. Pupils are 3 millimeter bilateral with sluggish reaction. Blood pressure is 95/60. Heart rate is 110. Saturation is 80% on room air, which subsequently, after intubation, increases to 96% with mechanical ventilation. The CT of the head shows right acute subdural hematoma with 8 millimeter midline shift with diffuse cerebral edema. He undergoes emergency decompressive craniectomy with evacuation of the hematoma and is shifted to the ICU, intubated and ventilated. And intraparenchymal ICP monitor is also placed. Now, as we see this patient, some of these patients can show a response, but this patient in the ICU course leading to refractory ICH over the next 12 hours shows an initial ICP of 12 to 15 mmHg with sedation with propofol and fentanyl and head end elevated 30 degrees, maintenance of normothermia, and ventilation with PCO2 target of 35 mmHg and a PO2 target of 90 to 100 mmHg. But despite this, at 18 hours post-op, ICP rises persistently to 28 to 32 mmHg. In spite of optimization of sedation and analgesia, in spite of ensuring neutral neck position with no venous obstruction, in spite of hyperosmolar therapy with 3% saline bolus initially and then mannitol, followed by mild hyperventilation to maintain PCO2 of 30 to 32 and an adequate MAP to keep a cerebral perfusion pressure of more than 60. So when this patient is still showing a rise of ICP, a repeat CT shows worsening diffuse edema, but no new mass lesion. The ICP remains 25 to 30 or more for more than 20 minutes on multiple occasions despite these measures. Now, this is a typical situation where we label as refractory ICH. If you go through this study, which was published in 2008, they were able to delineate this offshoots of demarcation quite precisely. And they found that refractory ICH usually refers to ICP persistently above 20 to 22 millimeter of mercury for 10 to 15. This was a narrative review, and they had included the studies and included the definitions what the major studies have found. And from there, they felt that it was, and it was subsequently adopted in the guidelines. So it was found that 20 to 22 millimeter of mercury for 10 to 15 minutes or more, despite optimized first tier measures such as adequate sedation, osmotherapy, CSF drainage, and mild hyperventilation, has been undertaken to their potential fullest. So this signals a high risk of herniation and poor outcome, and typically triggers escalation to the second tier and the third tier or the salvage therapies that are there for intracranial hypertension. Another review had also found that this high ICP episodes intermittently, they are frequent in severe traumatic brain injury, and they are independently associated with worse long-term outcome on the Glasgow outcome scale. So they are very important in terms of poor outcome. And that is why these should be identified and measures should be taken. And also patients' relatives should be counseled well in advance. So before a patient becomes refractory, we we usually follow the first tier management. And as I told, that should include adequate sedation or analgesia, head end elevation to 30 degrees, normothermia, optimization of PCO2, avoidance of hypotension and hypoxia, mannitol or hypertonic saline as the case may be, and CSF drainage where available, feasible, and needed. Many patients have ICP control with early surgery like evacuating of mass lesions, plus these first trial measures, and only a minority progress to true refractory ICH, which needs aggressive interventions. Now, when these patients need, then what are the therapies available? So when the ICP remains elevated, more aggressive, the tier 3 options include deep hyperventilation to target a PCO2 of between 25 to 29 mmHg, barbiturate coma, therapeutic hypothermia, and of course, decompressive craniectomy, if not performed earlier. Now, these therapies can control ICP, but they also carry a significant risk. And such risks include risks for hypotension, risk for infection, metabolic derangements because of very high levels of sodium, and even severe disability. So, therefore, this should be reserved for very selected patients after interdisciplinary discussion so that the benefits of the weighing the harm versus risks actually weighs in favor of the benefits. So if we talk about decompressive craniectomy, this is considered for refractory ICH when the maximal medical therapy fails because it can substantially reduce ICP by decreasing the intracranial volume capacity. Observational data suggests that decompressive craniectomy is used in less than 10% of severe TBI cases. And although it improves ICP control, the outcomes often include higher survival with substantial disability. So this requires a proper patient selection and family counseling. Family counseling is very crucial. The family relatives should know that even if the patient survive, they are going to have substantial lifetime disability and would require lifelong nursing care. So if we look into the barbiturate coma and hyperosmolar therapy, the barbiturate coma includes high dose of barbiturates like pentobarbital or commonly used thiopentone, which can significantly reduce acute and chronic ICH by decreasing the cerebral metabolic rate and the cerebral blood flow. But for truly refractory ICH, repeated boluses of high concentration of hypertonic saline like 14.6% that have been shown to lower ICP from around 40 to the 30s within minutes, with effects sustained over many hours when dosed serially. But careful monitoring of osmotic and electrolyte complications should be observed for, because a lot of times, although the patient's ICP may get lowered, but there can be devastatingly rising sodium, which can again retain water in other parts of the body, and there can be failure of the heart. Next is the limitations and complications of barbiturate coma, because high-dose barbiturates frequently cause hypotension. They increase the infection risk, particularly pneumonia. They cause gut hypomotility. So the same patient who was tolerating feed shows fails to tolerate. Prolonged ICU stay, aggressive vasopressor and supportive therapy are often required. Now, typical regimes include a loading dose. For example, for pentobarbital is 10 to 40 milligram per kg over several hours, followed by continuous infusion titrated to ICP control and EEG burst suppression or electrical silence while preserving the evoked potentials. Now, this may not be possible in every center, but at least clinically titrated to ICP control is something which is possible in most of the centers. But during therapy, one should be careful to monitor closely the ICP, the CPP, the arterial BP, if it is possible, EEG, as well as the organ function, because organ dysfunction can happen. And because the treatment often continues for several days and weaning is gradual once the ICP is controlled. We never stop immediately because there can be a rebound rise in the intracranial pressure. If you look into this original research, which is pentobarbital coma for management of ICH following traumatic brain injury. And you see this figure, which shows the GCS. And as you can see, from admission to pentobarbital initiation to discharge to last follow-up, this was useful. And the point which has been discussed is that with high mortality in these patients of severe traumatic brain injury, many patients surviving to discharge have poor functional outcomes. There, moreover, these patients, in patients with immediate response, it is seen that patients who had immediate response to pentobarbital, which means that within 1 day of initiation of this pentobarbital coma, they had an increased incidence of full functional recovery. So the initial response carries a lot of importance. So this has to be kept in mind while instituting barbiturate coma. In addition to this, there are some novel and adjunctive approaches. There has been talk about verticalization. Case series have been described where the patient is placed in near upright positions. This is considered as a non-invasive adjunct that reduces the median ICP and the frequency of ICP spikes in patients with intracranial hypertension, which is refractory to aggressive standard therapy. Now, such strategies are still experimental and are used only in highly selected settings, but they highlight that there is an ongoing search for adjuncts that can reduce the therapy intensity and complications in refractory ICH. Now, this is again one case series which shows verticalization for refractory intracranial hypertension. And here also, among the 6 patients, 5 of whom have SAH and 1 with ICH, the duration of verticalization, as you can see, actually was for a period of 10 days in one patient, the patient 3, and it was only for 1 day in a patient. So there is a lot of variation in the patient's requirement of the duration of verticalization, but there is no doubt that there is a significant fall in the ICP. Whether that fall in the ICP translates into real benefits in terms of outcome is not clear. Probably more studies are required. But there is no doubt that post verticalization, there is a fall in the median ICP values in most of the patients, and more so because it is a non-invasive intervention for lowering the ICP. Therefore, more studies are required to find out in which particular patients this can be a very important or a useful procedure. In terms of prognosis and decision making, patients requiring tier 3 therapies have worse prognosis overall. One large series reported favorable outcomes in only 40 to 45% of the patients receiving second tier interventions. This benefit was 50% overall in all patients altogether. That is first, second, third therapies altogether, and it was less. And this is quite understandable because these patients also already have more damage, and that is why they are resistant. And because salvage treatments may increase survival with severe disability, current recommendations emphasize individualized, goal-directed care and early discussion with the family members about the likely trajectories before escalating to decompressive or barbiturate therapies, because it is otherwise difficult for the patient to continue nursing such or their relatives for such long time. So the final take-home message would be refractory intracranial hypertension means ICP remains high despite optimal basic measures, and it carries a high risk of herniation and poor outcome. Escalation to second tier therapies like the hyperosmolar therapy, barbiturate coma, decompressive craniectomy must be timely and individualized, or should be performed timely and in an individualized manner. And each salvage option has major complications and may increase survival with severe disability. So early family discussions about the goals of care are extremely essential for these patients. Thank you very much.